to embrace positive aging. Great, so tonight we are here for Crafting Scientific. So the focus of tonight is to talk about self-care to enhance living your best atrial fibrillation life. Our expert panel today will be talking about bringing different perspectives about self-care of atrial fibrillation, including clinical, research, and personal perspectives. If you're comfortable, and only if you're comfortable, I would like to invite audience members to raise your hand if you have AFib, just so our panel members can have a sense of who's with us in the room tonight. Thank you so much. Great. Super, thank you. So I'll just briefly talk about the overall plan for this evening. So each of our wonderful panel experts will talk for about 10 minutes. And while they're speaking, please feel free to think of questions, jot down notes. If you need some pen and paper, I can bring them to you. Just put your hand up after I do my little spiel here. I can bring you a pen and paper, or you can just remember. After each of the panel members talk, we will take a short 10-minute break. You can grab some refreshments that are in the back of the room there. And then we'll reconvene the panel discussion. And this is when we hope to have an open conversation. You can pose questions to the panel and we can have a discussion as a group. Obviously, I'm using microphone. We can also pass the microphone around for questions, just to make sure everyone can hear well. And before we close the cafe at 7 p.m. tonight, I'll invite each of the panelists to provide closing remarks. A note that if anyone is interested in learning more about future opportunities, let's see, do we have students here tonight? Kathy, do we have students here? We have two research assistants. Okay, I think they're just setting up the coffee there. We have two wonderful research assistants who will direct you to so if you're interested in learning about future research opportunities, they would be happy to talk to you about that. We'll also be taking a few pictures of the event tonight, so if you do not want to be included in the picture, please let one of us know before you leave tonight. And with that, I'll introduce each of our esteemed panelists. Super. Already clapping. All right, so in order of speaking, so first of all, we have Dr. Kevin Pistawka, who is a cardiologist of over 30 years of experience practicing in Vancouver, Ottawa, and for most of his life in Kelowna. He is the medical director and the founding member of the Central Okanagan Association for Cardiac Health, otherwise known as COACH. He is also an avid sports enthusiast, enjoying golfing, hockey, skiing, and biking. Next on our panel, we have Dr. Kathy Rush, who is a professor and graduate program coordinator in School of Nursing at UBCO. Supporting people living with atrial fibrillation, particularly older adults, is a passion of hers, and she has been doing this research in this area for over a decade. Next to our panels, we have Dr. Peter Lowen. Dr. Peter Lowen is a pharmacist and associate professor of pharmacy at UBC Vancouver. For over the last 30 years, he has worked as a clinician and researcher with patients with cardiovascular diseases, and now spends most of his time doing patient-oriented research, providing patients with AFib, including patients with AFib, including understanding how and why they take or don't take their medications and the development of decisioning. And finally, just to my right here, we have Cheryl Sargent. Cheryl lives with atrial fibrillation, is 67 years old, raised 3 children as a solo parent, and is grandma to 2 great-granddaughters aged 7 and 5 years old. She obtained 2 degrees from UBCO in social work and worked for the same nonprofit agency in Kelowna for 22 years in a variety of frontline, supervisory, and management positions. She retired in 2020 and is a patient partner with this research team. And if anyone is interested in becoming a patient partner on our research team or more generally about patient partnership, we would welcome it, and you can talk to Cheryl about her experience. So with that, I will hand it over to Dr. Pistawka to give his remarks.
Thank you. Thanks for the introduction, and thanks for everybody coming tonight to chat about this obviously very popular topic. I've been tasked with sort of describing atrial fibrillation, what it's all about, and by the number of hands up, I probably don't have to spend as much time on that as I anticipated. And then I'm going to chat a little bit about where I feel there's certainly lots of room to personalize the decision making with patients and talk about self-care. There's some cases where it's pretty obvious what we recommend medically, but there's lots of opportunities in atrial to individualize things. So and then at the end, I'm going to bring in, just to keep it kind of even scientific-y, since it is a cafe scientifique. I actually bring in a couple of clinical trials that have just come out last year that illustrate kind of the data that we have and how important it is that research guides our decision making. And we're fortunate in cardiology. There's an awful lot of research information for our patients. Not just with coronary disease, but certainly with atrial fibrillation. So definition. First of all, this is a atrial fibrillation. It's many diseases. It's not one condition. It's a very, very heterogeneous group of conditions with many different causes, many different faces and presentation, and therefore many different treatments. I could see 20 patients in a week with atrial fibrillation in the office and treat them all slightly different. So this is kind of it's a very interesting disease that way, whereas a lot of our cardiac diseases aren't that broad. So definition. So this is a electrical problem, not a plumbing problem. We're not talking about coronary disease. We're talking about basically, I get down to the car. It's not your gas lines. It's not your valves. That's the primary issue. It's the distributor cap. It's the timing of the heart that has gone off. And usually because the atrium becomes irritable, and in some cases enlarged, the heart rhythm goes out of kilter, and it goes into this usually rapid, irregular rhythm. And that can sort of have three sort of different main categories that medically we look at. It can be paroxysmal, where it comes and goes kind of on its own. It can be persistent, where it comes and it's a hard time to get rid of it, and we need medical intervention, either meds or the DC hydro, cardioversions to shock the heart back into rhythm, or it can become permanent, where some patients are in it persistently, for decades and decades. It has many different durations. So when we see atrial fib on a heart monitor, we typically use somewhat arbitrarily a 30-second cutoff. So we don't call it atrial fibrillation if you have 15 seconds of irregular atrial beats. So we need 30 seconds, but majority of patients don't have 30 seconds. They have hours and minutes or days, and in some cases years of atrial fib. But that's the duration. But it is very, really quite variable. The risk we kicked, and there's many different causes. In some cases, the most common cause is age. So if you live long enough, you'll eventually get atrial fibrillation. It's also very common related to high blood pressure, related to valvular heart disease, sleep apnea. Interestingly, in high ends of athletics, so the triathlon crowd, they get more than their fair share. So there's lots of different causes but in a lot of cases we don't find the cause. The reason we care about atrial fib is that it's one of the leading causes of strokes. About 1 in 4 strokes that are KGH or rehab right now were caused by atrial fib. So that's certainly one of the most devastating complications of atrial fib. And if we let atrial fib go too long, too fast, the heart can wear itself out and go into heart failure. Usually that's something that we can reverse. So it's really heart failure and strokes that are the biggest medical concerns, but our patients' concerns are actually, while they worry certainly about stroke and heart failure, their concerns is how they feel. It's really just the experience, which is really quite variable in patients. Some of you may be surprised to find that we see atrial fib patients walking in for a knee replacement, and they have atrial fib and they have zero awareness. They have no symptoms. And other patients are highly symptomatic. They get atrial fib and they want to be in emergency 20 minutes later, and everything in between. So it has many different phases as far as the atrial fib. The decision making, when we look at stroke risk, there's lots of calculators, there's lots of risk research that has told us how to evaluate patients, how to risk stratify. So we use scoring systems. There's one called CHADS, which tells us, CHADS stands for congestive heart failure, congestive heart failure, hypertension, age, diabetes, and stroke. And we look at these factors and we can calculate the stroke risk, which for most patients is about 5 to 6% chance of stroke each year. You have atrial fib, and I believe risk of about 1% on average. And so we, in many cases, we'll recommend blood thinning. But we use these scoring systems, and we also have a similar scoring system for bleeding to decide whether patients have significant bleed risk. But fortunately, we do have lots of research, and one of the research, since this is a cafe scientific, before I get into where we can personalize care, research is super important, and there's observational research. So we observe that that certain conditions have a commonality, but observational research doesn't always give us the same answers as randomized research. We observed certain things about hormone replacement in women, and what we realized when the randomized trials were done, 20, 30 years ago in nurses, where they were actually a computer decided who got the hormones, we realized that much of our observation data was just wrong, because women who were given hormone replacement were very different than women that weren't given. So while you may have groups, one got them, one didn't, they're different populations. So we rely on randomized research. So one randomized research or one observation is people often say, well, maybe what about coffee? What about coffee and atrial fibrillation? So since this is a cafe scientific, and I like my coffee, and if I get atrial fibrillation because I drink a couple of cups a day, I'll just accept that. That's the question is coffee, is this an entity? Is it something we should worry about? And in fact, some of the data observations suggest coffee was a good thing.
Yeah.
So in fact, let's say, hey, let's do some randomized research. So this was just out. American Heart Association trial came out in November. It's called the decaf trial. It wasn't decaf coffee, but that was the name of the trial. The acronym off the top of my head, I forgot of it. They took two groups of patients, and it took a long time finding these patients, because patients, one group had to commit to not having coffee for 6 months. So they had to actually so they took half the group, said, okay, I'll give up my regular, at least I was a cup a day, or I'll give up my cup or two of coffee a day. And they randomized these two groups. And what they found was these were patients that had all had cardioversions. So the point of entry was you get the paddles, get your atrial fib back corrected. Half of them said, okay, I'll abstain from coffee. The other half said, I'll continue to drink my 1 or 2 cups of coffee a day. At the end of the trial, after a little less than a year, there was a 20% reduction in atrial fib for those patients that continued to take their coffee. So that was a win for the coffee craze. So for those of you having coffee tonight, I'm not gonna raise any eyebrows. So we can now personalize that. We can have recommendations. So when it comes to personalizing, there's a couple areas where I think there's a role. We know alcohol and atrial fib is a big deal. So patients getting cardioversion, usually, not always, but there's the patients that lie in that bed getting cardioversion often have alcohol intake that's double the rest of our patients. And so we have the role to discuss with our patients. And there's some of the docs might be hardliners saying absolutely you need to abstain. Others are less hardliners to say, hey, I live in the Okanagan, I like the glass. And so certainly alcohol, we will have a negotiation with our patients and help them decide, are they going to make a significant lifestyle change that'll certainly reduce their burden of atrial fib, as well as sleep apnea. We see some of our partners are really, really keen on getting patients on machines. Many patients are incorrectly told that if they don't buy a machine, they're going to have a stroke or die tomorrow. That's not the data. And in fact, I'm, much more willing to, negotiate with my patients. Do I think, buying a $2,000, $3,000 machine will have an impact on their atrial fib? And this is a shared decision. And to be honest with you, for most patients well into their 80s, if they've lived 80 years without a machine, it's very few that I would recommend going out buying one unless they clearly have, significant sleep apnea symptoms, falling asleep and significant fatigue. Exercise, usually we'll recommend exercise, and most patients know that. And so we'll often have negotiation, but the group that's hardest is that the triathlete who has atrial fibrillation and how you convince them that they have to dial back on their exercise. And is there data suggest that makes a difference? Not really. So there's certainly an individual decision making with those patients as to whether we need to what role exercise may or may not have for those patients. When it comes to drug therapy, we have some drugs that are pretty benign, might cause some mild side effects, but usually to stop the drug and everything is fine. We have a couple of drugs that have significant side effects. Unfortunately, one of our best drugs is also one of our worst drugs. So one of the drugs called amiodarone is a great drug if you have atrial fib, but it also can be a drug that is associated with side effects, thyroid, lung, liver, skin. So we have to have that negotiation. Are you prepared to accept the risk of this drug? Peter may talk about this a bit more about drugs. And then, most importantly, once we get out of the drug world, it comes into invasive procedures. And this is where there's a negotiation, again, with our patients. We are not in the stage in Canada where ablation or electrical therapies are first line. They're still largely done for quality of life. And so we actually have to have a good discussion with our patients. Are you prepared to accept the small risk of an invasive procedure, accept the chance that this procedure may not work a third of the time? And so we have to often have that a good discussion with patients. And some patients are clearly, sign me up. I want to do invasive. I want to, put tubes and catheters and little burns and freezing and now shockwave inside me, or alternatively, no, leave me alone. I can live with this. So certainly in the invasive, realm, we have good discussion with our patients, and we fortunately have three guys in the electrical group here, and the rest of the EP team that are very willing to have those discussions with our patients to navigate them down the route of invasive procedures or not. Some of the decision making is pretty clear cut. If you come in, you're diabetic, you're hypertensive, you're 70, and you have atrial fibrillation, usually we'll be pretty hard about our recommendations for being on the blood thinners. The data shows aspirin just doesn't work, so we're going to be pretty hard. But there's lower burden atrial fib, and where this becomes important is that one of the new diseases that we're now seeing is the Apple Watch atrial fib. And is that the same disease? Well, it's probably not. And in fact, we have some data from our pacemaker population. There's people that have pacers that didn't have atrial fib when they had their pacer put in. And now the pacer says, which is a 24-hour monitor, you have some atrial fib, and you had an atrial fib for 1 hour. And what does that mean? Well, it certainly means a lower stroke risk than our general population. And so we will now have data from a large trial called Artesia that we can now negotiate with these patients who have a relatively low burden of atrial fib. Should we be on blood thinners the rest of your life or not? Clearly, someone who's had, 10 minutes of atrial fib and had a bleeding ulcer and nosebleeds and hemorrhoids, we're going to be a little bit more, on the conservative side, where somebody who's had, 20 hours of atrial fibrillation will be, and has low bleeding risk will be more aggressive. The other area that we have negotiation on in the last trial is something called the OCEAN trial. So we have patients that have ablation is very successful. We used to say keep going on your blood thinners because it could come back, which it did in a third of patients. The question was, can we safely stop blood thinners after what appears to be a successful ablation once you've gone a year plus out and you've had no recurrent AFib? Well, again, we have some data from trials suggesting that is something that is worth discussing, that we are now recommending for the first time. Some of those patients could stop their blood thinners, but this is again a decision with the patient. Do we stop? What is the risk of stopping? What is the, or do we monitor for atrial fib with Apple Watches and whatnot? So there's certainly lots of areas in atrial fib because of the diversity of disease. There are many areas where individualized decisions, self-care, and personal goals and thoughts do play a role. So yeah, it's a great disease to talk about this topic today.
Well, that's part of the call. I have to say, it's probably installed. However, I'm Kathy, and I had a question on Oh, yeah, because I need to do this, so don't mind. I can raise my voice pretty loudly. Can you hear me back there? You can now?
Yeah.
No?
Yes.
Hello. Great stuff. No, turn out.
Can you hear me now?
Yeah.
There, okay, we are good to go. Yeah, so you can tell that how important our healthcare providers are to us, right, in terms of our AFib management. They help obviously guide in terms of like making decisions around treatments and about procedures, even about lifestyle, factors and so on and so forth. So they're very, very important. But did you know that on average, most individuals only spend about 10 hours per year with their healthcare providers. Now, this may obviously vary greatly, but on average, that's about it. And that means that really you're managing your AFib really independently with the provider. And we call that self-care. And self-care has been shown to really improve outcomes for patients with atrial fibrillation, preventing even relapse after a after an ablation, for example, reducing the amount of healthcare you have to use, and also costs that you might incur or that your provider might incur. And patients with atrial fibrillation do find some of those self-care decisions quite challenging to make. And that's because really they largely are making them in the real world with some degree of uncertainty, situations that arise that are very uncertain, that are not clear cut. And like you've talked about, well, should I have that drink of wine? Should I continue my exercise program? Should I seek care given, this compilation of symptoms that I have? So there are just things where patients are making these decisions independently and wanting to make the right decision. But with technology all around us and in everything we pretty much do these days, including our healthcare and cardiac care, our team became very interested in what the use of technology for AF self-care. And so we were most interested in consumer technology. So that's more or less like wearables and so on that are independent of the system or of your provider. And we asked patients, we invited patients, we have invited 6 groups of patients with 5 to 6 patients in each group to join us on Zoom in these group sessions too. And we asked them what their experiences were in using technology to make their self-care decisions. And so what did patients tell us? Well, the overriding thing that they told us was that using technology was highly personalized for their unique needs, their situations, and for their preferences. And we observed this personalized even when when and how patients really began their use of technology, because some patients when they had started using technology long before they were diagnosed with AFib, and they then started to kind of apply their technology to their AFib and monitoring their AFib. And then others really then adopted their devices when they were diagnosed. And then others, well after they had been diagnosed, did they decide to acquire some technology. And sometimes patients initiated it, and sometimes their providers actually recommended that they get some of these devices. But we found that patients they tended to use one or more devices. So some patients had just single device, some had many devices. Sometimes they use them continuously. Sometimes they use them just periodically. For their decision making. A lot of it really depended on, as Kevin said, were they symptomatic? Did they have symptomatic AFib or did they have asymptomatic? Did their AFib come and go? Was it quite persistent? That type of thing. And what was their preferred technology? So a lot of their use of the technology, one or more devices, really was on several personal factors for them. Patients we found overall were really quite sophisticated in managing and processing the data from their technology and using it really in terms of their decision making. And so I wanted to just share with you just a few of their approaches to decision making. So underlying their approach, really largely patients tended to use their devices really to establish their baseline. what was normal for them. And many of them were tracking and trending and analyzing their data over time, even keeping really great records, whether that was on paper, whether that was on their mobile, whether it was an Excel sheet online. They would have very meticulous records, and they would look at this over time, and they would determine really whether in fact there were any changes like in their blood pressure or their heart rate or the types of biometrics that they were collecting, just to see if things were staying the same, whether they were improving or whether they were not improving, and then want to make some decisions accordingly. But in some cases have been doing this for like over 10 years. Like they were like very conscientious and diligent. But another decision-making approach that patients use their technology for was actively keeping out of the danger zone. And by danger zone, we mean anything that put the patient at risk of an atrial fibrillation episode or might promote complications like stroke over that long term. But both symptomatic and asymptomatic patients use the technology really to do what they call self-diagnose and validate whether they were in atrial fibrillation or not. And if they were, then they had to think about, okay, what might be triggering that? Could it be that coffee, although the evidence is showing otherwise perhaps now, or could it be that wine, or could it be that exercise that I've been doing? And so and then they would change their behavior accordingly. So they oftentimes would make some changes in some of their lifestyle behaviors. For example, we had several who were quite avid exercisers. And during their exercise sessions, they would wear monitoring devices. So they would often wear a heart strap and be monitoring their heart rate continuously while they were exercising. And they would be checking it to see if their heart rate was going up. And if it was, they would then have to balance to bring it back into that low risk zone. So that's how they did it. And then asymptomatic patients also, those who didn't experience symptoms also that they used their devices because they weren't always aware whether they were in high risk, a high risk zone. What was I saying? My having some negative episodes because I don't even know. And so they would track it and determine whether they were or whether they weren't, and then make decisions accordingly. And I wanted to also mention too that the patients also tend to use their technology. And some of you may relate to this and may have other stories. They also used it for the medication management, and Peter is going to talk more about that. But they did, for example, they wanted to comply with their medication regimen, so they would set alarms right on their phones, on their smartwatches to just remind them to take their medication, whether that was an anticoagulant or whether that was an antihypertensive. And then some of them just use it really to monitor the effectiveness of the medication. So if I'm on this antiarrhythmic, is my heart rate showing that it's a little elevated? Is it really working? But then seeing that maybe it's trending downward, and I'm okay, I'm not in that high risk zone. It's controlling my heart rate, and I'm okay. So that was one other way. And then finally, watching and waiting was really a very common among the participants, and they tended to watch and wait to make decisions that were specific to seeking health care. And so they would, and the period of time that they watched and waited varied among patients. So patients really tended to kind of use a combination source in terms of making their decisions. They would monitor their technology, the data on their technology, determine whether it was at in normal range, baseline, if they were, what their bodies were telling them, and also what they were doing at the time. They would put all that information together and make a decision about whether they were to seek health care. But where we really found that it made a difference was in terms of seeking health care in the ED. Patients really use their technology to determine whether they should show up in ED. And in fact, some of them did use all those different sources of data to decide for them, including their data from their technology. And they would head off maybe within 3 to 4 hours of, having, what they thought was warranting going to the ED. But others would wait for a period of time, over days, that they would, determine whether in fact their heart rate was going up during sleep, and was it still sustained at this high level even when they were out engaging in perhaps bike riding or something the next day, and they would make a decision then that, yeah, I guess over time, watching my heart rate kind of trend up and not come down, I think I better go in, based on the way I'm feeling as well. And then there were those who simply avoided going to the ED because their technology sort of was a good validator of them not really having a high heart rate in that danger zone, even though they were experiencing symptoms. And so they just simply didn't go, and so they avoided hospital visit. But they did acknowledge that had they not had that technology, that they probably would have, gone to the ED. But the technology really, really helped them to make a decision that was really warranted at that time. But normalizing life, whether with or without technology, was really important to these patients. And patients who found that technology, some patients found that the technology really helped them to normalize life because they liked to be able to know what was going on. They could validate whether they were in AFib or not, and if they weren't, then they could get on with life. And that was really a source of reassurance for them. Other patients really didn't want to overuse technology. They didn't really want to be obsessive over their data, and they simply found that using the technology was really not normalizing life for them, and they just would check periodically to see if they were in AFib. And there were others that still, even despite settling into, using technology, they really felt that the only way that life would become normal would be really if there was a cure and they would be AFib free. So in conclusion, overall, patients did find technology very helpful in increasing their decision making, their confidence in decision making. They felt less in the dark, and much more in the know, making decisions that were really more intentional, purposeful, and really quite, they really exercised a lot of caution in making decisions about seeking healthcare, and were just hurrying off arbitrarily when the first symptoms showed. So we think that technology helps create potential for win-win solutions that both support patients and providers in the system.
Okay, thank you, Kevin. Thank you, Kevin. So on my short walk over from the hotel to here, I realized the state of my French, and so I had to look up what a café scientifique and what it was supposed to be, just to see if I could in any way fulfill the idea. And probably the most important thing I learned was that there should be coffee.
There is, yeah.
And there is now, I understand, that's wonderful. There's also supposed to be wine.
Oh, no.
Yeah, which there'll be a more ironic and opposed array of beverages to be talking about at a bit related event tonight. So here we are. Eventually, I hope you get to enjoy the coffee, and you'll have to go to a third location to find the wine. So the things that you guys have brought up already are very cool in the sense that the things that I was thinking of sharing my thoughts about keep sort of pushing the boundaries of this whole topic. And so the first of them and most of what I'm going to say is meant to maybe provoke you and maybe seed your thoughts about things that you want to discuss and debate after the talking to a microphone part of our time is over. So I really do invite you to share your thoughts and opinions about some of these things that I raised. I know that's the spirit that everyone here wishes for us to be in tonight. But so the first collection of thoughts I thought I would share with you have to do with, so for many patients with atrial fibrillation, many people with AFib is how I'll refer to us from now on. Stroke prevention, as Kevin mentioned, is one of the main focuses that we have from a therapeutics point of view. And that means taking anticoagulant medications for many people, but not all people, but for many it does mean that. And so I thought I would start out with something very grounded, and it has to do with the research that we do in my group, and that has to do with patients who are taking anticoagulants and really do they take them or don't they take them? Now, I know the people that sign up for a Cafe Scientifique, those of you who did translate that into what this actually is, and then come to a library to do that are very different from the people who with atrial fibrillation who are not. So all of you take your medications that you're prescribed completely reliably, 100% of the time, et cetera, et cetera. So what I'm going to say here is food for thought and things that you might share with your friends and loved ones who chose to not be taken. Maybe you're not interested in atrial fib, but we recently done a series of kinds of research that have been recently published, and we showed that about a third of people with AFib that don't take their medications reliably, meaning to taking 80% of them as prescribed, or 80% of the doses as prescribed. And so, and that's British Columbians. We studied about 100,000 residents with AFib and shown that. And a question that flows from that as well, who cares and what's the impact of missing a third of your doses, which has led us to do another body of research where we've shown that that missing several days in a row of medications, especially the new kinds of medications, the new oral anticoagulants, the DOACs, these are your apixabans and dabigatran, rivaroxabans and edoxabans that many of you are familiar with. Missing even a few doses of those increases the risk of stroke in the subsequent days by about 35%. And so the risks, the short-term risks of missing a few doses in a row are very pronounced. The risk seems to be a little bit less if warfarin is the anticoagulant that you're on, and many of you know there's reasons to be on that and many good reasons to not be on that as one's anticoagulant. But the risks with DOACs are especially great, and a simple way of thinking about that is that they're relatively short-acting medications. You're not really anticoagulated 24 hours after you've missed a dose of one of those. And so we've been able to see that those impacts are really quite great. And then the last thing in this vein is a paper that just came out that we did quite recently, just came out in the fall, where the question was how much taking is enough taking? Because we like to think of things in binary terms, you know, what's a good blood pressure for me to have versus what's too high. And so if we try to make it a binary, an A or B phenomenon, but if I take 80% of my doses, is that good enough? Is 90% good enough? Do I have to take 100% of them to get all the benefits? And what we've shown is that when we're the first two is that taking 90% of your doses, in other words, missing less than one dose a week, is basically necessary to achieve the benefits of the bulk of the benefits of the new oral anticoagulants. On the flip side, this doesn't apply to any of you, but tell your friends and loved ones. On the flip side, taking less than 90% of your doses, in other words, taking less than 6 out of 7 days a week of your doses, is associated with between a 20 and 50% increase in risk and stroke with those short-acting new oral anticoagulants. And so there are many great things about those medications. They have become the mainstay for very good evidence-based reasons of stroke prevention and atrial fibrillation. And adherence to them, taking them as prescribed, is proving to be, from what we can tell, especially important. Okay, another domain of thinking is around the idea that's been brought up already by both Kathy and Kevin, is that we think about decisions in AFib. It really brings to mind what I imagine is your experience, which is that it's a bit of a journey. And it's a little bit different maybe in hypertension, where one day you find out you have hypertension and now you have hypertension, and you know, we manage it throughout our lives. We have to make some adjustments to keep it at target. But atrial fibrillation is a journey in more complex ways. You know, you start out with a few symptoms and then you kind of maybe get diagnosed or don't really get diagnosed. And then one day something happens that results in you being told that you have this condition. And maybe now we're deciding whether we're going to start stroke prevention therapy for that. Now we're talking about perhaps, do we want rhythm control? Should we be taking rhythm controlling drugs, antiarrhythmic drugs for that? How deciding whether to do that or not? maybe we do, how does that go? Does it work? Does it keep me in the sinus rhythm? Does it keep me out of atrial fibrillation? Okay, it is, but now it's not so much anymore as the years go by. Now I'm having symptoms again. Now I know there's a thing called ablation. Should I be talking with my caregivers about ablation? Do I want that? Am I a candidate? I do. Okay, now I'm on a list. And now I'm on a path to get an ablation. Okay, now I'm lucky enough to have gotten ablation. Was it successful? Was it not successful? It was successful. Okay, so now I can stop taking anticoagulants and I'm through the end of the journey and I'm now a person who doesn't have a fib and doesn't have to take medications for it anymore. Okay. Very long story to tell you what you already know about the journey. And all of those decisions that are happening along the way to pick up on what Kathy was saying are obviously very profound and significant. And this takes me to sort of the last domain that I want to mention, which is what you were saying, Kathy, about how we spend so little of our time in direct engagement with our care providers in all the ways that we have them, physicians and nurse practitioners and pharmacists and nurses and physiotherapists, and, occupational therapists, dietitians, and a great deal of decision making that patients can be supported in happens outside of all of that. And picking up on what Kathy said, a tool for that is a decision aid. And so these are the instruments that many of you have been exposed to in relation to AFib. Maybe it's an app, maybe it's a sheet of paper, maybe it's a website that you've been pointed to where you ask questions and tell them things about yourself and your age and whether you've had a stroke or not and this sort of thing. And from that, education happens, you learn about what your risk of stroke is, what your risk of bleeding is, what your risk of maybe going on to develop chronic AFib is, that sort of thing. And there are many, many patient decision aids in atrial fibrillation. And the provocative thing that I want to, and if you're like most people, atrial fibrillation is not the only condition you deal with. And so other domains of medicine and care are ahead of us in the AFib world. The cancer people have been using decision aids for a long, long time. Surgeons have been using them for a long, long time to help patients understand their risks, to help them choose which procedure from a surgical point of view or which type of cancer treatment is best for them. So some of you have experienced decision aids in that context, and they've been proven to be extremely useful. So the provocative thing that I want to leave you with is there's a bunch of AFib related decision aids. Almost all of them have to do with whether you should be taking an anticoagulant or not. And very few of them have to do with, am I the right kind of person to have an ablation? How would I decide if I wanted to even talk to my caregivers about ablation? And so very few of them that exist concern those other kinds of decisions on the journey through atrial fibrillation. And there's very great need for more of those so that people with AFib can be making these decisions, or I should say, educating themselves so they can, when they get a chance to be with their care providers, are educated, armed and equipped with the information that's personal to them, that they need to be able to have that conversation with their expert care providers and make a decision together. That's the idea of shared decision making that Kevin started this on by thinking about. And so the last idea to leave you with is a 10,000 pound some kind of animal, maybe it's an elephant or a gorilla or something like that, that's in the room, and that's artificial intelligence. And is anyone here a user of AI? Okay, yeah, some AI lovers here. Has anyone done a Google search in the last year? You know, an AI user. So we all know that if we Google anything now, that it's AI that's answering us and synthesizing that information. And so AI, because this is a cafe scientifique, we're allowed here to venture into advanced territory when it comes to this conversation. And this, I very much invite your thoughts about this. But AI has already very thoroughly done to infiltrate the world of atrial fibrillation. In diagnosis of atrial fibrillation, there's now very reliable AI tools that can look at a normal ECG or the normal output of someone's Apple Watch ECG while they're not in AFib and they've never been diagnosed with AFib, and fairly reliably predict whether sometime in the future they will experience AFib. And so this is where we're already at in terms of AFib. I'm not saying that this is in routine use by all of your care providers. But this has been shown. It's now possible to take pictures of the back of your retina. If you're a person who's never been diagnosed with AFib, pictures of the back of your retina, 3 pictures, and that can be fed through an AI model, and with about 80% reliability, predict the future occurrence of AFib or not in you. And there's even been some studies where just taking photographs of people looking into a camera, just their faces, we can detect AFib, predict its future occurrence. Okay, so we're already there. I know that's scary, but it can't be scientific, right? We can talk about these things. My point is that the fact that AI is now infiltrating not just that, but many other when ablations are done. AI is used to help the clinicians that are doing ablations pick targets for where to do the ablations. And I can teach us more about that, I'm sure. So it's already here. In the world of decision aids, AI is becoming more and more of interest. And so just to bring it back down to earth, if you had a app on your phone that was a decision aid for AFib, and it told you that it was AI enhanced, like, you know, everything's AI enhanced now, right? The menu at a restaurant is being claimed to be AI enhanced in some way. If you knew that it was AI enhanced, you know, what would that mean to you? And what would you want to know about what that means? If you were told that it's good that it's AI enhanced by someone you trust because the decisions that it helps you make are better and it helps better guide you, what kinds of things would you want to know? Some things that we know that patients think and feel about this is they wonder justifiably about things like, is the advice that it's giving me suited to me, given my sex, my gender, my age, my race, my ethnicity, the other conditions that I have, and those kinds of questions. These are very important questions for people to wonder about. Another is there's a whole domain about how inequities in care could be perpetuated by AI tools. And kind of along the same lines of the things that I said, is that they could miss giving advice to people inappropriately. They could give incorrect advice to people inappropriately based on misunderstanding sort of who you are and where you're coming from all the viewpoints of things that we said. To people that don't have the resources to own a computer, use a computer, be good at computers, have a fancy computer in their pocket. The inequities associated with an increased reliance on AI. I'm giving you all the caveats first, and there's many more that you can think of, and I want to hear your thoughts about this when we have time for Q&A. So those are all the caveats. Then I just want to finish my bit of time here by telling you a story. A thing that I do now, I don't know, once a month, is I sit down with ChatGPT and I sit down with Google Gemini. There are others that some of you like. I haven't played around with those ones. And I just am the patient who is, I make up characteristics about myself. And I say, I'm having trouble deciding whether I should start an anticoagulant. I'm having trouble deciding whether I should be even thinking about ablation. And I don't even know what I should think about. Is basically the stuff that I say. So maybe some of you maybe try this for yourself, or with your own information, or just experimented with it. And so on a provocative note for me to finish on, what comes back to me is, to me, absolutely extraordinary and absolutely profoundly valuable in terms of shaping my thinking. So I'm speaking for myself. I'm not making claims about having scientifically validated ChatGPT or Gemini in this regard. But even it coming back to the end with, here are 5 important questions for you to bring to your next appointment, with the cardiologist or electrophysiologist or GP. Right down to that, I found incredibly useful. And so that is, I finish with that, not because it's an endorsement, it's my own experience that I've been having. And when I think about myself as a person who cares about decision aids for patients and wants them to be better and wants them to be more of them and for them to be more used and more useful, it's very challenging for me to think about what the decision aid that I or people that I know could come up with that could be even touch the usefulness of just being in conversation with these tools that are like here now and free and available, and that many of you have already experienced the use of. Okay, so I'm purposely not coming down with an endorsement there, that hopefully is enough to provoke you to for us to argue about that afterwards. Okay.
Well, this is a hard act to follow on, but I just want to thank youth professionals for, you know, the amazing contributions that you've contributed to the world of AFib, because I learned so much from this, so thank you. I am a very curious person. Can everybody hear me? I got a loud voice and I don't know if it's carrying back there, but I'll keep going. So I'm pretty curious, and Alex had stolen one of my questions. And that being how many have been diagnosed with AFib here. The other, though, as I was thinking, was how many people, if you're willing to share, knew what AFib was before you were diagnosed? Interesting, very interesting, hey? Yeah. So anyways, that I'm just curious around that whole perspective, because I didn't know either. So just a little background context for me. So I grew up as the oldest of 5 children, and heart disease ran through our family. I was fortunate enough to know my family history. My both paternal grandfathers died of heart disease, as did my dad. And my mom had been diagnosed in around 75 with AFib. Excuse me. After she had an aneurysm rupture. So I, in hindsight, always wonder if she had AFib undiagnosed for many years. But anyways, so that's a little bit about my historical family stuff. I was aware that I was experiencing some kind of symptom for approximately 1.5 years before I was officially diagnosed. And that looked like thumping chest symptoms, rapid heart rate. And usually, of all things, I was more aware of it at bedtime. I wasn't aware of it during the day. And then I joined a gym, and I noticed that they had digital device that they put on you to keep track of your heart rate and whatever else. I can't even remember now because that was a number of years ago. And the device was acting erratically every now and then, and we thought it was the device itself, right? And we could never figure it out. It wasn't all the time, just occasionally, and I just continued on with my activities. So it's the discovery of AFib for me was a long and winding road. I found I was tired more often, and my doctor of 30 some odd years retired, and I managed to find a new doctor. And I had talked to the old doctor, the longtime doctor I had, about possibilities of this, what I didn't know what was going on. And we hummed and hawed about it, but atrial fibrillation really didn't come up. And then after he retired and I managed to find a new care provider, I happened to meet her for the very first time, and lo and behold, I just happened to be in AFib. And she sent me right off to the hospital for an ECG, and I'm like, okay. Like, she's going, do you know your heart rate is this fast? And I'm like, no. So I was really, quite shocked at that meeting. And so I drove myself to PGH and went to the heart clinic, as many of you probably know the heart clinic. And got confirmation that I was in AFib. I was diagnosed shortly thereafter by a cardiologist here in town. at about 60, so I've lived with it for 7 years now. He diagnosed me with, say, Dr. Kevin, paroxysmal. I hate that word. I hate it. You never say it. Yeah, I know, but it's just like, I want to be, kind of the expert like the rest of you guys are all out there. So anyways, what I discovered that through that process of all the assessments following diagnosis, which many of you have probably had with blood work and EKGs and echocardiograms and Holter monitoring and sleep apnea assessments and discovering your age as a contributing factor possibly and lifestyle. Right, and then blood pressure monitoring was another thing that I was unfamiliar with, really, and I was like, really? So I just found that after all that, I really kind of learned that this whole atrial fibrillation is a tricky heart rhythm to catch, like actually catch, and it took a long time. And I'm thinking in hindsight, good God, I could have died of a stroke. Or, in hindsight, but I'm still good, thanks. So it was really a confusing, tiring, and frustrating time for me. And it really cramped my active lifestyle because I'm a very active hiker, skier, cyclist, walker, go on and on and on. And so it really, because I was so tired and, I'd have an episode that would last for hours. Even with medication at times. And so, I once I was diagnosed, I was really determined to educate myself about this heart disease. And I discovered, as the panelists have talked a lot about, that there's different types of AFib, and there's various symptoms for people. It affects genders differently. There's various contributing factors, there's various treatment strategies, like it was a lot of information. And then COVID hit, and I had learned about, and I was on medication, got onto a regime of medication, and had to buy a pill box and do reminders to take my meds because I was told of the importance of these. And I was a little resistant at times, but I just thought, okay, I gotta do the best I can here. And then I discovered at some point within the first year about cardiac ablation, and then COVID hit. So I put that strategy on hold because I knew the hospitals were overwhelmed and just everything else, but it was always in the back of my mind. I did go for sleep apnea testing. Initially, they discovered I was mild to moderate. I did a trial with the machine, and I tell you, I hated it. Hated it. And this was again 7 years ago, roughly, and I had to take sleep aids in order to sleep. And I'm thinking, well, there's no purpose to that. So anyways, I abandoned that idea for the time being, knowing that it was a contributing factor. That was the choice I made. So then comes the period in time where I really wanted to find as Dr. Smith talked about, the invasive cardiac ablation. I was put on the referral list. It was, I think, 15 months before I managed to have the procedure. And I had complications. I was a third of the people that had complications, but we went through the 3 months of amiodarone treatment. And I'm happy to say that I'm almost 2 years symptom free with 2 mini breakthroughs episodes. And so for me, if I continue, I may go for a top up at this point in my path. So part of contributions for my heart disease, I grew up in an environment with cigarette smoking and secondhand smoke. I was also a smoker for a period of time in my lifetime, and with that, I've been now 8 years smoke free, so that I'm happy about that. I do imbibe in coffee and the occasional wine, and I've never discovered a treatment for my AFib. I've thought, I've kept track, I thought, okay, I have coffee, I have wine, I can, spicy foods, all those kind of things. I have, when I had my breakthrough episode last July for 5 days, I tried to think, I just got back from a Europe trip. I was away for 2 weeks, it was the best trip I'd ever had, and I'm having episodes, and I'm like, what the heck? So, anyways, so those, I guess in all the process too, the decisions that mattered most for me was really getting into the technology piece. Knowledge first and foremost through evidence-based research informed websites around what atrial fibrillation, getting on this research committee group. I like that. I've learned for me, I think increasing knowledge provides me with a little sense of control over this heart condition, for myself. I look at all my medical people as my consultants now, they are the experts in things, and I'm the decider in how I want to be treated. So for me that those people, and I'm talking from the nurse practitioners to the specialists to the hospital ER staff, hospital heart clinic, pharmacists, they're all like just amazing people in this journey for me because I can really lean on them. The digital technology, for me, I really had to up my ante and get comfortable with it. How many are know about cardiac device, the cardio device? Yeah. So if you want to take a look at a cardio device here, if you haven't used it, that's been a game changer for me, and I can send my readings to my cardiologist who will confirm my AFib episodes and make recommendations immediately within a very short period of time. I've been really happy with that process. I guess so. I don't wear a watch ever, so this is more like a little bit of an ECG. Is that what it is with the smartwatches? Yeah, I don't really watch. I carry this around with me, just in case. And I think I've already talked about cell phone apps, getting comfortable with those, and the CPAP usage. After my ablation, I did decide to give it another go, and I got assessed, and my sleep apnea had significantly increased from 7 years ago. So I decided to do another trial, and the technology has changed significantly, and I am happy using it for the time being. So it's just one of my treatment strategies, and yeah, because initially I was so resistant because it was such a horrible experience. The catheter or the cardiac ablation is a very highly technological digital procedure, as the panel has already kind of discussed. And yeah, it didn't come without its complications, but I would do it again if I needed to. Let's see. And knowledge and digital device uses for me have increased and maintains my decision making independent of providers. So I can look at, should I maybe just take a rest? Should I go for a walk? Should I maybe go to the clinic? Should I maybe I need to go to the ER? So I started thinking about those things, and I'm a little more confident in my decision making about where I'm at, using some of these digital things. And what else? I guess for me, just wrapping up, some of the challenges over time for me has been catching the atrial fibrillation. I feel that at this point in time, there needs to be more prevention, or exposure of what atrial fibrillation actually is. Some of the challenges, again, another challenge is some tiredness with periodic breakthroughs. Now I've been, it's recommended for me that if I do have an episode that I have where I will, take a Pistawka, if I'm familiar with that medication. And then see if it, helps with, the, episode at the moment. And another challenge was the wait list for the cardiac ablation, and another one is no travel outside the province for 3 months after that procedure. And last but not least, travel insurance has become very, very expensive. So on that note, I'll hand this to you.
On the. Super, thanks so much, everyone. Let's just take a 5-minute break and please stretch your legs, grab a coffee maybe, there's snacks, water, there is a washroom kind of like downstairs, maybe and on this level as well, just down the hall. So just a short break, folks, and we'll come back and have a